morning, good afternoon, and good evening, depends on where you are. Thank you for coming and joining this AAST virtual grand rounds. Today's session is hosted by the AAST International Relations Committee. My name is Alan Guo. I'm the trauma surgeon and a professor at the State University of New York in Buffalo. I am the chair of the International Relations Committee of AAST, and I will moderate today's session. Our focus today is on global trauma care. Of course, we are the International Relations Committee. So we are honored to have three international trauma leaders with us to discuss the infrastructure and resource availability in different trauma systems worldwide and how they compare to North America. We have three speakers, and the first one will be Dr. Hsee. He's a consultant, trauma and acute care surgeon, and clinical director in general surgery of Auckland City Hospital, and immediate past binational co-chair of trauma committee of the Royal Australasian College of Surgeons. And he is also the ACS NISCIP International Scholar of 2015. The second speaker is Dr. Henrique Alexandrino. He's a senior consultant in general and emergency surgery of Coimbra University Hospital, professor of surgery in Faculty of Medicine of the University of Coimbra, and the president of the ALTEC, Lusitanian Association for Trauma and Emergency Surgery. He is the chair of the DSTC committee in AAST, the International Association of Trauma Surgery and Intensive Care. Our third speaker will be Dr. Kumar Menon. He's a senior consultant of trauma and vascular surgeon and center director of the National University Center of Trauma in Singapore. So each speaker will have 15 minutes, and then we have about 10-15 minutes for question and answer. A quick note, AAST no longer offers CME for live grand rounds. If CME becomes available for the archived version, today's attendees will receive an email once it's on the AAST website to claim the CME. And the attendees today will not be able to ask questions verbally, but you can type the question in the box provided in the Q&A. And during the discussion session, I will ask our leaders, the speakers, and we'll hear from their answer in the discussion. With further ado, let's get started. Okay, our first speaker will be Dr. Hsee. Lee, go ahead. You are muted. Lee, you're muted.
Right. Can you hear me now?
Yes.
Okay, can you see my slides?
Yes.
Okay. Hello. Thank you, Ellen, for the kind introduction. I'm Hsee from Auckland, New Zealand, and I'd like to thank Ellen, our International Relations Committee Chair, and AAST for the opportunity to talk a little bit about New Zealand trauma system. I'm being cheeky that I put my titles as Kiwi is more than a bird that does not fly, but it's really about a New Zealand, a Kiwi trauma system, a quick snapshot. Kiwis are flightless birds, endangered birds and endemic to New Zealand. There are 5 different species that usually last 25 to 50 years. It has a significant national significance. It's an icon. It's a symbol for uniqueness of New Zealand wildlife and the value of heritage. And colloquially, it is referred to a New Zealand people and the New Zealand system. And so therefore, I entitled this talk as Kiwis trauma system. I just tell you a little bit about New Zealand health system. It has recently underwent restructuring, and it is founded on collaboration, partnership, and shared leadership. It has an ambitious goal to achieve Paiora, which is a Maori word for healthy futures for all New Zealanders. The core health services are publicly funded and universally available, and most of the health services are provided directly through Health New Zealand, and it's also called Te Whataora in Maori, and there are other crown entities. New Zealand has approximately 5.8 million people, and there are 3 islands involving Northern and South Island, and it is divided into various regions. New Zealand trauma system is integrated and is complex. It is divided into 4 regions. Most of the population live in the Northern Island, therefore there are 3 regions. And the South Island covers a larger geographical area, and it has its own trauma network. And the national instance of major trauma is 51 per 100,000. And today I'll talk a little bit about the pre-hospital system, our hospital facilities, a little bit on the rehabilitation and our national quality improvement programs, and what's going on in terms of research and education. New Zealand has the full regional network, and they kind of come under the overall Health New Zealand governance, and there's a national trauma clinical network. Accident Compensation Corporation is a fairly unique entity. It belongs to the New Zealand government. It provides a sole compulsory provider of accident insurance for work-related and non-work-related injuries. It is fairly unique in a sense that it does administrating New Zealand's no-fault accidental injury scheme, and it provides treatment, injury, and financial compensation for all New Zealanders, residents, and visitors. So if you have an injury on the New Zealand soil, you're pretty much covered for your treatment here in the country. Because of its importance, it has a dedicated ministerial portfolio. Major trauma mechanisms in New Zealand are blunt, mostly are related to transport-related injuries, followed by falls, small numbers of penetrating injuries, although we do see them. And this is a national trauma network data on the major trauma mechanisms. And South Island and Northern Island have the highest volume of major trauma emissions. In terms of pre-hospital system, they are ground-based or air to cover the entire geography of New Zealand. There are 2 charitable organizations, mainly are public funded, but approximately 20 to 25% of the funding comes from private donations. On the ground, there's a Order of St. John's ambulance service, and there's a Wellington Free ambulance service. In terms of air provider for pre-hospital injury treatment. Their helicopters can be dispatched, and their rotary wings for transport from remote area to the major centers. The majority of pre-hospital staffing are paramedics, and there are different grades of paramedics, from a basic paramedic personnel to intensive care paramedics. The intensive care paramedics will have the ability to do finger thoracostomies at the scene or intubate patients at the scene. In some cases, the doctors will accompany the paramedics to manage difficult or complex trauma injuries on the field. New Zealand has a national out-of-hospital triaging policy, and the mandate is that patient who meets major trauma criteria should be transported directly to the most appropriate major hospital that is feasible and safe. And as I have mentioned, there are 4 regional trauma networks, and each regional trauma network has its own designation policy. And over the last few years, there's been work done on the management of critical hemorrhage, a consistent critical hemorrhage protocol for accelerated clinical care. Trauma facilities, New Zealand's a small country. In 2022, there were 22 district health boards, which are local hospitals. This was transitioned to a unified nationwide entity called Health New Zealand, Te Whatu Ora. And the acute injured patients can be treated either in the public or in the private sector. And they are covered by ACC, Acute Compensation Corporation, which I have mentioned. But the severely injured patients are managed in one of the 7 tertiary hospitals across the North Island and Christchurch in the South Island. The major trauma hospitals do provide subspecialty cover, but not every hospital has all the subspecialties, which I'll illustrate in Auckland region where I work. These subspecialty covers are vascular neurosurgery. There's a national burns unit and burns network, and plastic and reconstruction coverage, and major centers has cardiothoracic surgery support. New Zealand has a pretty good rehabilitation program. There are burns. There is a acute brain injury unit. There are 3, one in Auckland, one in Wellington, and one in the South Island. There's also dedicated spine rehabilitation, one in the North Island and one in the South Island. They are good, pretty good older people's health, as our population is getting older like other parts of the world. We're trying to have a good older people's health network for their rehabilitation. Approximately 17 to 20% of our patients discharged with a major trauma are required to have some form of rehabilitation. This is Australia-New Zealand Trauma Registry. It is a binational data registry, and there is a committee to provide report and oversight of the report publication. There is a Australian report. It is binationally, but I just put a slide up there to give a snapshot of just New Zealand, not in Australia. The 2022-2023 trauma registry data. In terms of demographic, close to 2,000 majorly injured patients. Majority of those are male. as you can see, that blunt injury predominates 94%, and penetrating injuries is very small, although we do see stabbings and gunshot wounds here in New Zealand. The numbers are small. Mostly are reported by majority of patients are transport-related injuries, followed by falls, and approximately 45% of those occurs in the highways. The median time from injury to definitive care in New Zealand is 1 hour and 48 minutes. Median time to spend in ED is 4 hours and 48 minutes. 8.1% of in-hospital death. 45% of those deaths occur in patient age 70 or above, and 6% of those patient deaths occur in the emergency department. 53% of those patients gets to discharge home, and I have already mentioned approximately 20% of the patient will be referred to rehabilitation. In terms of quality improvement program in Australia and New Zealand, the ANZ Trauma Registry leads a binational clinical quality registry. Over the last couple of years, the focus has been on the data set for major trauma in older persons greater than 50 years old, and we're able to benchmarking our outcomes and work with the trauma hospitals across Australia and also in New Zealand. In New Zealand itself, there's a New Zealand Quality Safety Commission leading along with a New Zealand Trauma Network, and they have focused on national protocol for hemorrhage and the consistent management of traumatic brain injuries. The Royal Australasian College of Surgeons has a trauma committee, which I was previously involved as a chair. There is a very good trauma quality improvement group. And currently in New Zealand is really, we are focusing on the inequity of health outcomes, especially for our indigenous people, the Maoris, and also the Pacifica people who are living in New Zealand. These are just some of the quality improvement process indicators from the College of Surgeons. I think this is fairly consistent for all the hospitals that we get our information from pre-hospital transport times to timing the CT scan, when, whether the patient had blood alcohol collection, and the time to definitive care, and the time in the emergency department, and of course, mortality. Here's a snapshot of the major trauma hospitals across Australia and New Zealand. Royal Melbourne has the highest major trauma admissions, followed by Royal Perth. The circles in black are New Zealand hospitals. Our trauma hospitals, Christchurch has the highest volume, followed by Auckland City, and then Waikato, Middlemore, and Wellington Hospital. In terms of trauma education and research, New Zealand has a big focus on injury prevention, and injury prevention occurs in multiple health sectors, from government agencies to private sectors to university and academics. And the trauma committee in New Zealand has a trauma advocacy group to work on the injury prevention, such as recently on domestic abuse, and also drowning, which has been an issue over the summer. And they are teaching and educations. We have regular ATLS courses. The definitive surgical trauma course is being taught here in Auckland, and also pre-hospital and nursing education programs on trauma. This is fairly unique, and I just want to mention, because New Zealand is a small country, we actually have the entire New Zealand trauma system which underwent verification by the College of Surgeons in 2017. And I think this is fairly unique. There was a formal review and recommendations on patients' journey from the time of injury to treatment to rehabilitation, and look at the resources that we have in New Zealand. And there is a high level aspect of trauma care system, from governance to the current structure and trauma policies, and of course, our quality improvement program. I just want to, before I finish, I just want to talk a little bit about the Auckland region. I have mentioned that not every trauma hospital has all the services, and this is where I work. I work in Auckland, and Auckland has approximately a quarter of New Zealand population, and it has two major trauma hospital and one pediatric trauma hospital. Auckland City Hospital is right in the city, and as you can see, that geographically surrounded by two harbors, and the Children's Hospital is right next to the Auckland City Hospital. So we see adult trauma patients, and patient under age of 15 will go to the Starship Children's Hospital. And there is a Middlemore Hospital, which is approximately 20 kilometers south of Auckland. And in Auckland City Hospital, we have a dedicated trauma service. There's a neurosurgery, cardiothoracics, and vascular surgery. And where in the south of Auckland, in Middlemore, they will take isolated spines. The National Burns Unit is located at Middlemore Hospital. And the plastics and reconstruction services are also in Middlemore Hospital. Occasionally, if the designation policy has not gotten the right patient to the right place, we may need to do the definitive care first, and then we transfer it to our neighboring hospital for the secondary treatment. So in summary, I think at the moment, I think New Zealand or Kiwi trauma system is fairly unique, and it has really matured over the last few years with the hard work of trauma providers. And we have learned or updating our trauma system through our international collaboration especially with Australia, but also internationally as well as my colleagues in US, Singapore, and Europe. And I think that currently we have a very good collaboration with the QI quality improvement group and research, and continue to focus on education. And our current focus is obviously improving the KPIs and improve the equity outcomes of our Maori and Pacifica group of patients. So this is, I will leave you with the Auckland City picture, and I will invite you to come to visit us in New Zealand and have a good look around. So thank you very much, Mr. Chairman Alan, for your invitation to present, and I thank the AAST for the opportunity to give a snapshot of New Zealand trauma system. Thank you.
Thank you, the wonderful presentations. We have questions at the end. So the second speaker will be Dr. Alexandrino. Henrique?
Hello. Can you please check if I'm sharing my screen?
We don't see your screen.
What now?
Here you go.
Okay.
Yes.
Well, hello. Thank you very much for the kind invitation. It's a pleasure to talk about the Portuguese system for trauma on behalf of the Lusitanian Society for Trauma and Emergency Surgery. It's a pleasure to join the AAST Grand Round, and I salute everyone, especially the speakers. No disclosures. This is Portugal. It's a small country, roughly 10 million people, located in the west part of Europe. It's located, it's well known for the good food, good wine, nice sightseeing, nice people, but there is a dark side and there is trauma mortality. We have some numbers which are, I would say, hampered by the fact that we have not been able to develop a well-matured trauma registry. But in any case, you can see that mostly blunt trauma with increasing violent crime, especially in the major cities. What most people don't know is one of the greatest inventions, one of the recent inventions of Portugal, was this system that avoids these long queues at the toll systems, which is the Via Verde, the green pass or priority lane. It's an electronic toll system where you just drive through and your bank cars will be discounted on the toll charge. Well, this concept of the green pathway or the enhanced pathway is applicable to trauma, and our government in 2022 promoted a regulation that all hospitals should have a concern on the chain of survival of trauma from the pre-hospital care to rehabilitation with this concept of a green pathway. And I will develop some of the aspects of this green pathway in this talk, starting with pre-hospital care. In this, our country has made some excellent steps because due to this National Medical Emergency Institute, INEM, which was founded in 1981 and is a comprehensive coverage of national territory and integrated with rescue and security systems, provides an excellent coverage of the entire country. There are several capacities. We on the top, you have several, which I would say the basic response, the ambulances, which are covered by paramedics, firefighters. Some like this immediate life support ambulances are nurse and paramedic. And at the bottom, you see the more advanced, usually with a doctor, like the VMER, which is the staple of the Portuguese pre-hospital response. One doctor, one nurse. Obviously, the helicopter with the helicopter crew, doctor and nurse, and this ambulance, which is for pediatric inter-hospital transfer with a pediatric intensivist and a pediatric nurse. But the staple is, of course, the VMER, these emergency medical vehicles. The crew is one doctor, one nurse. The philosophy is mostly stay and play, obviously because the predomination of blunt trauma, long distances from rural areas, and in selected cases, they provide a rendezvous with the last advanced transport, meaning that the VMER will meet halfway the ambulance, do some stay and play the patient, and then transport the patient to the trauma center. And this is all coordinated by a regional dispatch center, which is regulated by INEM, this National Emergency Institute. What happens when the patient arrives at the emergency room? Well, there are many hospitals, but there are 7 level 1 trauma centers. I work in Coimbra University Hospital, the largest hospital center in Portugal, over 2,000 beds. It's a level 1 trauma center for 2 million inhabitants in the central region of Coimbra. And basically all centers have cardiothoracic, neurosurgery, pediatric surgery, burns units. So there is a comprehensive coverage of the country regarding trauma centers with the other, we'd say level 2 or medical surgical hospitals providing primary care or damage control to victims that do not reach the trauma centers. Regarding the trauma team, also there are strict regulations on this. The trauma teams are mandatory for level 1 and level 2 trauma centers. The trauma team coordinator is either a surgeon or an ICU doctor, but must have training in advanced lab support. And the trauma team activation criteria are mainly, as usual, as you'd expect, physiologic, based on immediate or potential threat to airway, breathing, circulation, or nervous function, anatomic criteria, or mechanism of injury. More importantly is how are the teams organized. And in our hospital, we have developed this horizontal approach based on the European trauma course, where one team leader coordinates a team of other 5 elements with an airway doctor and a breathing doctor that are assisted with one nurse and a circulation doctor that is assisted by a second nurse. We provide this horizontal approach for trauma management, where under the coordination of the team leader, most aspects of the trauma management are taken care of. The trauma team coordinator is contacted by phone by this ambulance dispatch center, The at-missed handover is provided by phone, and the trauma team leader becomes a trauma team coordinator, and the team is usually composed of either anesthesiologist or ICU doctor for airway, ICU doctor or surgical resident for breathing, and the second surgeon, or in some cases, orthopedic surgeon for circulation. What is more important is that people are allocated to their roles. So it's not really important what specialty you belong. You become an airway doctor, a breathing doctor, or circulation doctor. So in best ways, the team leader will be able to do a team briefing, role allocation, and allocate further resources like master transfusion protocol, OR, radiology, or other specialties like neurosurgery, plastic burns, maxillofacial, etc. How do we train our providers? Well, in the first hour, in the inter-hospital management, we have two main courses, non-competitive. We consider them, and our position at Altec has been that we do not consider these two courses competitive, the ATLS and ETC, but they're complementary. The ATLS for the, I would say, junior provider, and the ETC for the trauma team leader. But what happens is that these courses mainly train doctors of specialties and don't train the entire team from the same hospital. And we know that there are several issues with the trauma management regarding the human factor, that the trauma team training can reduce mortality, especially in higher severity scores, and that most errors in trauma resuscitation are related to failures in communication. So our institution started in 2001 and our local trauma teams course, where we one day simulation scenarios, mostly focusing on non-technical skills. We train the entire team, doctors and nurses, according to our hospital's own model. So we don't have to feel like we're artificially developing. Our motto is we simulate like we work and work like we simulate. We've had 24 editions since 2021. And we trained over 300 professionals, and we had training also teams from other institutions. We assessed this with a pre-post survey where we found that our team members are improved their confidence, their view of the importance of pre-arrival briefing and post-resuscitation debriefing. So our initial experience is very, very positive. We designed this according to local protocols, and we focus on non-technical skills, and this improves perceptions on the role of teamwork. So continuing our Via Verde of trauma, we go into the operative management. And here Portugal has had one great advance in the recent years, which is the inception of the subspecialty of emergency surgery. It's a very recent update by the Portuguese National Medical Association, and it's designed to build a specific curriculum for general surgeons. They're mostly general surgeons involved in the surgical management of visceral trauma in Portugal, like I would say Southern Europe. And this is to provide in increasing subspecialization in laparoscopic robotic surgery, have a quorum of specialists in trauma management, non-trauma emergency surgery, disaster management. But also we need to develop training the trauma team. And this is one of the main things that our society, Altec, has been related with a memorandum of understanding with YATSIC to do the joint DSTC, DATC, DPNTC courses. We provide a realistic immersion in a simulated trauma operating room. So it's much more than a surgical technique course. And we try to implement several technical issues, but also non-technical issues regarding perioperative communication. The Portuguese trauma system, however, is not perfect. We identify some key issues, and one of them, I would say the most important, is the delayed implementation of a national trauma registry. We don't have interpretable data to implement policies. You cannot change, you cannot improve what you cannot measure. We need benchmarking with other European centers. We need benchmarking among ourselves, with our centers. And we also needed to take trauma team training to a national level. And also we have one challenge, which hopefully we'll solve in the near future, is to develop surgical teams, qualified surgical teams, and implement this subspecialization in emergency surgery. So I provided you with a quick snapshot, I hope, of Portugal's integrated dedicated pathway. We are very proud Via Verde. Pre-hospital care are highly developed and well-organized. Trauma teams are becoming a reality, and they're being a reality in different ways. They're being trained according to local protocols. And the concept of trauma team can extend to operative teams, not just surgeons, anesthesiologists, but also perioperative nurses. And obviously, we know that training, postgraduate training, is essential, and it's a powerful tool to improve outcomes. Our small society, Altec, has owed its work to our leaders, which are here in the photo. You may know some of them. We're very small, but we're affiliated with the Brazilian Trauma Society and with the European Society of Trauma and Emergency Surgery. And I thank you, and I bid farewell. This is a view of Coimbra, and I hope we can meet in the future, and I'm available for questions at the end of the talk. Thank you very much.
Thank you, Henrique. So now let's go to the third speaker, Dr. Raj Kumar Menon.
All right, and good afternoon, everyone. And it's early morning here in Singapore, and glad to join you. And thanks, Prof. Allen, for the invitation as well. I'm Raj. I'm a trauma and vascular surgeon, and I'm the director of the National Trauma Unit at our Ministry of Health, and I'm the president of the Asian Collaboration for Trauma. And I will be very happy to collaborate with any of you in the audience as well. And we'll put up some of our links down the line in both research, clinical care, and education. No conflicts of interest. Today, I'll give you a quick overview of historical perspectives of trauma in Singapore, being a very small country, pre-hospital services, regionalization of trauma within our small nation, and our disaster response framework, and a little bit about training and then some use of technology as well. Singapore in the 80s and the 1980s didn't really have a trauma system, very decentralized. We did have an island-wide ambulance system, but specifically no registry, no specific trauma surgery plan, and no disaster management plan. Mortality was high, but over the last 2 decades, a series of steps that we undertook as a nation has seen our mortality rates drop significantly. And this was the journey that our country undertook, appointing a National Trauma Committee in 2008, having a national registry with all hospitals contributing to it in 2011, establishing standards of care across many hospitals, having a national trauma unit to support trauma initiatives and policy, and then finally regionalizing trauma care as well. And the Singapore being a very small country, you can drive across the entire country in 45 minutes. So to give you the scale of the country. So it's a complete scoop and run concept because there are hospitals which you can get to very quickly. So very short travel times. If you call an ambulance, they will reach you by 10 minutes at the latest, and you'll be in the hospital within another 7 minutes or so. And because of that, the things that we do on scene are very limited. We just a bit of oxygenation, needle decompression, give some TXA fluids, packing, tourniquets, but nothing more drastic. And certainly we don't intubate patients or anything apart from doing supraglottic airways with the LMAs, and nothing really surgical going on in the pre-hospital service. It's all electronically and networked. So the moment the ambulance arrives on scene, they have body cams, and they enter data into an iPad, which then gets transmitted live to the emergency departments so that we can prep for these patients before they arrive. Because we have such a short pre-hospital time, any information that we can get from the scene helps us. So on-scene photos, vitals are electronically sent over to the emergency department before they arrive so that we can prep for these patients. And we have many hospitals in Singapore. These are government hospitals, and they take on 80% of the workload in the country. I'm in the western part of Singapore, with a population of around 2 million, and my hospital is the major trauma center for this region. And if you follow AAST's levels of trauma, there are about 3 level 1 trauma centers across the island. We are the first regionalized group, so wherever you are injured in the West, based on the diversion criteria, you'll be brought to the major trauma center, and you'll only go to the other hospitals, the partner hospitals, if you have a traumatic cardiac arrest or an airway emergency, and we see adult and children as well. This is the pre-hospital diversion criteria, which is used by our paramedics. So they look at injury mechanism, they look at hemodynamic instability, and they look at the mechanism of injury to then determine, do I bring you to the nearest trauma center or not? In terms of disaster response, trauma volumes in Singapore are low, very, very low, and majority of our trauma is blunt trauma. We haven't had a gunshot in decades, and I think the only gunshots we have very occasionally is a misfire of one of our security agencies when they go to the washroom, that kind of a thing. So it's and mostly limb injuries, so very rare to get penetrating trauma in the country, and not much in terms of disasters or terrorist attacks as well. So it's fairly safe. And I think ever since, I mean, in the last 2 decades, there hasn't really been a mass casualty incident. However, it's just a matter of time. We're a country which has a long history, and we're surrounded by many nations where there's still a lot of conflict going on. And because of that, I'll be always worried about when is the next time we'll ever have a major terrorist attack. And so we have been training mostly with other conflicts around the world by deploying to other military zones and engaging in disaster relief for our neighbors who unfortunately sometimes do get quite a lot of natural disasters. If we do have an event, the Ministry of Health coordinates the entire response, and we have different incident managers, the Port Authority, the airport authorities, and the civil defense teams who actually manage the on-scene response. And it's a whole of country effort. The moment there's a civil emergency in our plans, essentially we have forward medical team from the hospitals who deploy on site, and they start up a first aid post and then focus on evacuation to the hospitals. And there's a tiered system of these forward medical teams where the public hospitals push them out first. The military comes in, and the military also sets up infrastructure, and the Red Cross. And we get additional ambulances from the military. So quite a strong civilian-military integration in this disaster response. Each of these teams, 2 doctors and 4 nurses, and depending on the number of casualties, then we would send larger and larger number of these to the forefront to provide some immediate management while we are evacuating them. And again, depending on the number of casualties, we activate either just the immediate hospitals or the whole region or the whole country, again, to distribute the casualties across the nation. Most of the on-scene treatment would focus on ATLS, and again, a bit more than scoop and run, but at least some stabilization. But again, we don't set up a field hospital because we have so many hospitals which are nearby. This is an example of so this is a mechanized vehicle which comes up and kind of transforms into an area for treating of severe casualties, and for the non-severe casualties, there are some satellite areas as well. And these are the hospital workers that have come in. So this was an exercise done simulating an air crash at the airport. And for those who are the walking wounded, we tap on our primary care networks to divert these patients to them so they don't clog up the hospitals as well. Again, because we haven't had an incident to learn from, thankfully, we do a lot of preparedness because we have to be prepared because we don't have that experience which other countries may do. So every hospital has every hospital of all the multiple public hospitals we have, they have to go through Ministry of Health run major incident exercises where we flood the patients with 300 live patients. That means we use our nursing and medical students as patients, and we flood them with about 300 patients each time. And then we try to see where the bottlenecks are, and we try to learn from that. And each hospital learns from each other. And there are very regular cycles for every year planned up a decade in advance, so everyone knows when are their cycles and when do they go for their actual finale exercise when they have this big flooding of casualties coming in. Just some pictures from some of the exercises that we have in our hospital. And essentially, it's a really whole of hospital effort when these occur. And every 3 years, we go through this. For decontamination and for hazmat, we use mannequins so that we can practice the washing off of these casualties as well. A lot of it is IT centric now. So we are trying to move away from paper cycles. And a lot of it is actually, and there's actually a punitive aspect to it. So if you don't maintain a certain set of readiness, your funding gets cut. So there's a lot of emphasis put in to ensure that you have proper funding. And one big focus has really been on moving away from paper processes to use electronics and AI to help us a little bit, creating dashboards which are automatically updated so that so hospital administrators and even the trauma team has a clear idea of resource utilization. And these are dashboards which are created, which are fed in from Epic, which is our electronic medical record system that we use in Singapore. And yeah, it's been quite useful because compared to paper play and Excel forms, now it's a bit more auto-generated and removes a lot of that cognitive load when we're doing that. Just touch a little bit on trauma training in Singapore. It's very similar to the States, I suppose, a very ATLS centric. And you go for DSTC run by the AAST group for both surgeons, anesthesiologists, and nurses. However, we are thinking of bringing in ASTET as well for our surgeons, which is which is quite predominant in the Americas. For pre-hospital training as well, most of our paramedics they do go for either diplomas or degrees thereafter and learn a little bit about pre-hospital care. So one big challenge, and I'll just end off with this in the last few slides, is how do we train in a low trauma volume environment? Clearly, we do send a lot of people overseas to gain experience, and all over the world. We send them to South Africa, to UK, to all high volume trauma areas in order to get experience and come back. But we also use a lot of simulation, and not just the traditional simulation using low fidelity mannequins, but with the high fidelity mannequins. And now we're moving on to extended reality simulations as well. So one of the programs that we run in our university hospital is a gamified version where we mimic one of our disasters we had, which was a highway collapse about a couple of decades back. We had about 10 casualties there, and essentially we kind of recreate that in a virtual reality environment, and our students then put on these headsets and they practice being in that environment to learn triage and ATLS. And these are not too costly. At the same time, they provide a multi-sensory experience with audio, haptics, so the controllers they use can actually feel the pulse when you put it to the neck, etc. Not sure whether you can see that it might be a bit choppy on your end, but this is what the students will see. So you have a casualty there. You can choose. We kind of gamify it. The vital signs change based on what you have selected. If you choose wrong, your vital signs drop, and in that way, they get a bit more interested in things like that. There's a variety of things. You got airway procedures, you got all your chest procedures, you can apply a binder. And when you do that, you can see there's apply the bandage. You can see the bandage appearing. And we talk a little bit about triage priority. So when you're given a time to treat as many patients as they can, when these patients, they're having a look, they can see the vitals are poor based on the screen over there. And based on that, they can choose what they want to do, whether they want to apply, let's say, a binder, or they want to do anything based on the physical exam. So each of these mannequins have got, so when it's here, they've applied a C-collar, they're giving some oxygen, you can see those appearing, and the vital signs will change accordingly. And so
you can put a tourniquet. Yep, the tourniquet should be applied on already.
So here they learn the basics.
Does it have a pelvic fracture?
And when this is done, the trauma surgeons would be around.
Put on a binder, but your tourniquet is already on. Yeah. Which is probably the correct thing you needed to do.
So what they are seeing, we can see, and then we can choose. So in this case,
give it a cannula, you can give some
patients
fluids,
hypertensive, and there was many games to choose their correct interventions.
Okay, correct.
So we have a large data bank of casualties that we use for this. So and the students like it and they feel real, and it helps to garner some interest in trauma and emergency care, which we use to try to prop up our numbers as well. So just to conclude, it's a very unique trauma system because of our size and urban density. It's a low volume, but again, high risk of major incidents. And because we're so urbanized, casualty numbers would be high. So scoop and run system broadly, most and all trauma is handled at public hospitals with a few major trauma centers. And beyond traditional training, we're moving on into using VR and extended reality as well. Otherwise, thanks again for the invitation to speak. I'll be very happy to link up for either both research or any other collaborations in education. Feel free to catch up, and for those who would like to get involved in with the rest of Asia, I'm happy to collaborate with you guys as well. Okay. Thank you very much.
Thank you, Roger. And thank you all of you for sharing your experience and let us learn about the different trauma system in the world. Really, we benefit from this kind of discussion. So let me see if any question posted. No, there's no question. I have several questions to ask you all. The first question is that we can see from all these three countries, the penetrating trauma is so rare as compared to the United States. Even in a good town like where I'm living, Buffalo, we have about 5 to 10% of penetrating trauma, including gunshot and stab wound. So I was thinking about, in 2022 in New Zealand, there was a mosque attack or gunshot in Christchurch. And so my question is that, is there any specific training programs for the surgeons or like medical professional in all of your three countries, particularly in light of the increasing frequency and unpredictability of terrorist attacks? How can you prepare for this?
Maybe I'll just start from a country which sees probably among the lowest rates in the world. You're right, it is a problem. So the way we encounter that is by sending patients, sending many of our surgeons and our emergency physicians to high penetrating volume countries. I was in a major trauma center in London, and I think I saw more stabbings there in a week than I have in a year in Singapore. And that's what we do. We go to where the trauma is, and we learn from there. We do a lot of cadaveric and animal courses as well to teach exposures, and so that so that people are aware of what to do. And in a lot of our training programs, we emphasize a lot on it because we know it's rare. And so when it happens, we do need to be able to be prepared. But the short answer is we go outside of Singapore to learn, and we try to go as many courses as we can, especially for vascular exposure, so that we can tackle these.
Welcome to the United States.
Yeah.
I just Alan, I just add a little bit about the New Zealand experience. You have mentioned the mosque terrorist attack, which we have 50 penetrating injury casualties all at once presented to Christchurch Hospital. And, this is a small country where all the surgical services kind of rally together to support our colleagues down in Christchurch for managing these penetrating traumas. There was a good system regarding, for example, the chest side of injuries. The cardiothoracic will take the lead, and the general surgeons will take the leadership in the abdomen, and of course orthopedics. And for the surgeons in the other parts of the country, have also offered to help. In Auckland, we had couple of cases was a transfer up from Christchurch for further surgery after the stabilization. But one thing that we have learned from this is also on the injury prevention from gunshot violence. New Zealand's gunshot violence volume is fairly low. We see them in the farmlands or the from game members, but the government and injury prevention group have tightened up the gun legislation in New Zealand, banning all the semi-automatic weapons, and there is a mandatory gun registry. So I think even though it's infrequent for penetrating gun violence injuries, the injury prevention side of things has been beneficial for the future.
Thank you. Henrique?
Yes, that is a great question. And this actually prompted our creation of the subspecialty of emergency surgery. Because, as you know, blunt trauma is increasingly non-operative management and geography and embolization for solid organ injury. But penetrating trauma is the most surgical trauma. And this particular training program in the subspecialty of emergency surgery promotes the DSTC courses, obviously, which are very important, but also promotes rotation in organ procurement, in organ transplant, in the organ procurement operations, which we believe is an excellent training for these exposure maneuvers in the live tissue, which is the cadaveric, brain-dead cadaveric organ, the Kettelbrasch, the Mattox, the supraceliac aortic clamping, opening the diaphragm and isolating the intrapericardial inferior IVC. All these maneuvers are practiced in the organ procurement operation. I think this is a very good operation for fellows, senior residents, younger fellows, to assist or even do some stages of this operation, and this will provide them with the confidence to work in a trauma patient in the penetrating trauma. So again, training with this particular opportunity, which we believe is important. Obviously, we have very good conditions for this in Portugal. We're one of the countries with the highest brain dead donor ratio. So there are plenty of opportunities for our surgery to train, and we do not want to miss this as a training opportunity for the future trauma surgeons.
Thank you. Henrique, I have another question to ask you. Several years ago, I have an opportunity, a privilege to mentoring a young surgeon from Portugal through the AAST, and we're doing a project and we're collecting data to compare the TBI between Portugal and the United States. And we found that there's no quality improvement in database from Portugal. The question I want to ask you is it feasible for the EU as a whole to establish a unified trauma quality improvement program and a database across its member states?
That is an excellent question, Alan. We are working with AAST and the European Society of Trauma and Emergency Surgery. As recently is about to publish, we're in the process of reviewing the final manuscript. The guidelines, European guidelines for trauma, which are not just scientific, are the applicability of the guidelines in each country. Obviously, Europe is a very large and heterogeneous region. And one of the, I would say, main goals is that we have a unified trauma registry. This has been hampered by several factors because, in fact, Portugal has already acquired the software of the German trauma registry, which is a very complete and very thorough registry, and would allow us to benchmark our results with Central Europe, Germany, Austria, Switzerland, and Denmark, I believe. And we're hampered, and there is an obstacle, which is the data protection regulation. Once we get over it, we will start a registry and hopefully implement a pan-European registry, which I believe is would be very, very good.
Thank you. Another question for you. I think Roger has already spoken about that, about the out-of-hospital management, the two major models that they wanted to scoop and run, the other one stay and play. So in New Zealand and in Portugal, what is the model that you use?
In Portugal, unless in large urban areas where scoop and run would take in effect, for us would be the stay and play for the pre-hospital teams.
I think we have shifted in New Zealand to scoop and run, Alan, because we now have a very robust designation policy. So, the paramedics actually knows what to do, and they follow the national guidelines to get the patient to the right hospital. But, life-threatening injuries at the scene, such as an airway issue, they would manage that on the field. And as I have mentioned, finger thoracostomy if required on the field, and they can do that. And then they now carry blood in the pre-hospital setting, and so that they can start with transfusion, and the helicopters has got ultrasound scan, so they will do a EFAST en route to the hospital.
Thank you. The last question for Roger. We have been doing the research study about the mode of transportation, helicopter versus the ground transportation, especially in big city during the rush hour. So I want to ask, I think you say in Singapore, you can drive from end to end only 45 minutes. What about during rush hour? Do you have ever used helicopter for transportation?
So in Singapore, rush hour is not too bad, and the reason is because vehicles are incredibly expensive here. I'll give you an example. If you were to buy a very simple, let's say Honda, a simple entry-level Honda in US dollars, it's going to cost you around 100,000 easily,
Oh
just
my
to buy a
goodness.
car, and that lasts you for 10 years. So the car population is young, and they're very few, and it's not as, so you don't get these big jams that you see in the Asian cities because it's so expensive. So that's number one. So because of that, and once you have an ambulance, the way the lanes are arranged, that the ambulances are able to go quite quickly. There are going to be some times when you get really bad jams, Taylor Swift concerts and all that, and then you get these really bad jams. But apart from that, probably not. We do use a helicopter service for offshore. As you know, in Singapore, it's a conscript army. All of us serve the military and are currently still in the reserves. And for much of our training is done in the offshore islands, and that's where our helicopter squadrons will go and do search and rescue and pick up and bring back and evacuate them back. So my other job in the military is I'm in the search and rescue squadron, and so we deploy anywhere over to the South China Sea or to our or to the islands where we do military training to pick up casualties, and then we drop them back in the hospitals here. But within the nation itself, no, we don't use that, and it's purely all land transport.
Thank you so much. Now it's my local time 6:02. Thank you, the speaker, for getting up early or stay up late. Thank you very much, and thank you for sharing your rich experience in the trauma system. And thank you for all your attendance today for the grand round. I would like to remind you that to please submit your signing sheet to the AAST office by this Friday, February 14th. So thank you and have a great night, great day.